need to, at least in your own mind and with your organization, talk about how you deal with that, how you might debrief regarding what you see or hear and things like that. Additionally, you're going to assist with crime victims compensation. There are specific laws regarding that we'll talk about in just a bit. And that can cause one of the most confusing things to people, not only advocates, medical providers, and the patient themselves. The people that you would provide this to, so your service recipients, certainly you're going to have victims of sexual abuse, sexual assault. You may be in a setting where you provide this care to children. You may be in a setting where you don't provide this care to children. You may only provide the care to adults or teenagers over a certain age. So again, you'll hear me say throughout this that it's very important to understand your policies, your organization, and what it is that they expect from you. Okay? Might be providing this to non-offending parents. If you've got children that you're seeing in the emergency room or in a specialized clinic, you're going to have the parents there, and they're going to be your primary recipients of the services. And additionally, you may have significant others. If you've got a teenager who may bring her boyfriend of 3 days in and want them to participate fully in the examination, you're going to be providing advocacy and support to that significant other. You may have a husband, you may have elderly parents, you may have significant others. It's very important to understand that you would be providing these services, again, within the context of confidentiality and consent for sharing of information to other persons associated with the patient. So I'm going to switch gears just a little bit here and start into the actual nuts and bolts of providing care. One of the things, and again I keep stressing, is that you really have to know what you have in your area. So in Snohomish County, we have a very comprehensive sexual assault nurse examiner team, and we provide care to a wide variety of patients. You may not have a team. You may have an emergency room that has one nurse that's been trained, and most commonly they would have been trained at Harborview. But one nurse that's trained, and they call her and see if she's available to come in. You may have an emergency room that has no trained nurse at all, and they are sitting with the kit, and in this kit is a really nice little step-by-step way of doing it. I can tell you that doing it untrained and with a little checklist is not the most ideal way to do it, but it may be the only way that you've got available to you. If you are in a remote area, it just may not be applicable that they could train and have a nursing staff available to them. So you may have a SANE team, sexual assault nurse examiner. You may have a SAFE team, sexual assault forensic examiner. You may have that lone nurse that has been trained in sexual assault nurse examiner. You may have a nurse that's never done one before. You may have a doctor who does everything and just has a nurse standing next to them. Also, you may have a physician's assistant or a nurse practitioner. So prior to walking into an emergency room, it's always in your best interest, and usually your organization has already developed some form of relationship, and in your individual training they will have told you this is what we do, this is how you talk, and this is who you have available. Just as you may have a variety of different providers that are working with you with varying degrees of experience and knowledge as to current standards of care, you have a variety of different medical sites. For the purpose of today, because it is the most common place that you would be providing medical advocacy, I'm going to talk about the emergency room. However, you may have a specialized clinic. You may have a child advocacy center, or what we call a CAC. You may have a general clinic up in San Juan County. They initially go to the local medical clinic, and the local medical clinic will triage and then contact us. You may have a school clinic, and you may go to a school clinic because the nurse has called and said, I really need someone to come out and assist. And you may have a correctional facility. And how you do that, again, is very, very dependent on your organizational expectations. We go to all the correctional facilities. We do not take an advocate with us. In the United States, we have what's known as the PREA Act, the Prison Rape Elimination Act. There is somebody in every jail and prison that is considered the PREA liaison or the PREA advocate, and that person is supposed to be providing information and acting as the advocate. So again, it's unlikely you would go to a correctional facility, but it's something just that you could ask and say, what's the policy if there's a rape in a correctional facility? We're always asked, why do a medical assessment? There's a variety of reasons. Most people only think of the fact that there is a case, that evidence needs to be gathered. We need to make sure the patient is okay, address any injuries, and provide them with the expected standard treatment and care. In reality, there are a lot of other reasons that we end up doing medical assessments. Certainly one of them is to gain the history, and I will repeatedly talk about that the history is the most important aspect of a medical assessment. So we want that history. It's also the most important thing in a case. It also drives any medical decision making, including the gathering of forensics, what sort of injuries they may have, what sort of risks they may have medically that we need to address specialized to them. And this history includes a medical history also. Are you allergic to any medication? What's your gynecological history? Do you take any medications? So there's a general, just standard medical history that we'll conduct also. We want to locate injuries, and certainly it would be great that we locate acute injuries. Most injuries in the genital region are going to heal within 3 to 5 days, and then there's very little evidence that there was an injury. Almost more importantly is what we call sentinel injuries. An example of that is, in the history, she tells me that she was sexually assaulted 6 months ago, and I will ask, did anything hurt while you were being assaulted? She replies, yes. Did anything hurt after? Yes. How long did that pain afterwards hurt? Well, you know what? Every time I went to the bathroom, it stung and burned for about a day and a half to 2 days. That's a sentinel injury. That tells me that in all likelihood she had an abrasion externally and most likely around the opening to the vagina. And most likely in the fossa navicularis, and this is not an anatomy and physiology class. However, that's the area directly underneath the vaginal opening and the most common area for injuries associated with sexual assault. I can go to court and I can say, this is what she told me many months later. She has no reason to believe that I know that that's a sentinel injury, that I know that this is probably what was going on. And I can testify to that with a reasonable degree of surety. So again, you are not going to know that. She's not going to know that, and we certainly don't want you to alert her to any information, just as you don't want to provide children with information. You don't want to provide anybody with information that's going to alter how I can give that information in court. I want her to not know why I'm asking those questions. It certainly is going to allow us to provide treatment. It's going to allow us to educate. It allows us to provide them with advocacy services, and that while I